Thank you. That was short. The others don't need to be that short, although, you know, as chair, it's always good to have short questions. The next on my list is Gahr from Senegal.
Thank you. And thank you for ISFiT, because I have to thank all these volunteers who make it happen. For deep, you know, in my heart, I really want to say I have any present for you, but thank you. Yeah. Yeah, my question was, of course, for the foreign minister, but also for this brilliant guest we have here. I'm from Senegal, and I see Norway, by her first foreign minister, talking about the relation between, you know, what they have with the small or undeveloped countries. I was going to say, and I think the minister will get my opinion about health. Health is not only medical. Health is also about education, but education not only this foreign language like English, Spanish, or French. It's related about linguistic. It's related about what people can understand about just giving them training. A couple of months ago, you know, in October, I was far away in Senegal, in the south. Maybe some people will know the region is Kolda, and the village called Bagadaji. We go there to talk with the women and, of course, the girls, because they don't know. We have these MDGs, we have all this wonderful thinking and imaginations, but people in my nation, in my country, they can't understand it because they don't speak French. And I really like, because health is not medical, then health is also how we can get educated. And these collaborations between different countries, they don't not limited about with ministers, but go in the ground, go in the communities, make basic community radios, for example, how to train them by using their own languages. And if they want to do it, they have not to limit it with the government, they have to go on the ground, you know, like far away, and it will be really important to think that these MDGs we really need to understand it, but we can't understand it just using French, English, and Spanish. Thank you.
It is really true that health is an end product of so many other sectors in society: education, water, sanitation, empowerment, this strange word empowerment, nutrition, not to forget, which seems to have gone a little bit out of fashion to talk about nutrition and food security. It's kind of, you know, these things go in fashions, but thank you for reminding us that it's not just health services. Do you want to comment on it? No? The next on my list is Naomi.
Good evening, I'm Naomi from Kenya. It's very interesting what you talked about, training midwives to carry out certain processes in the hospitals. But like in my country, there are very many people who are trained as doctors and nurses, but then there is brain drain, because if people are going to go through 13 years of education, they want to have good salaries. So how do you also make sure that when you train them, they don't go now to Western countries to work because they have better employment benefits?
We have made studies in Mozambique, prospective studies over 7 years, where we have followed medical students, graduates coming out from medical school in Maputo. We have such a school in Maputo. And we have followed for 7 years also these técnicos de cirugía, the non-physician clinicians in Mozambique. We followed them for 7 years to see how many of them after 7 years are still at small rural district hospitals. Can you imagine the difference? Among the non-doctors, 88% were still there. Almost 9 out of 10 were still working after 7 years. Among the doctors, the figure was 0%, which is quite telling, isn't it? So these people that we are talking about now, that we think would be much better to focus on because they do not escape, they are not currently at least drained away to other countries. They may be drained from rural to urban areas, that's a possibility. But our task now is to give them such good conditions, deployment, training, satisfaction, and also, let me say, an acknowledgement. We can call it academic or career or whatever, but they should be recognized. All of them are called doctors, but they are not doctors in the faculty sense of the word. They are non-physician clinicians, but they are highly respected by the population, and the population cannot distinguish that white coat from a doctor's white coat, because these people I'm talking about do all surgery we know of. Traffic accidents, trauma, anything, cesarean sections, and quite difficult operations. Of course, they save lives, and we should create conditions for them to stay on. But the impending brain drain risk is there, because if we make them more and more skilled, they may be drainable. They may be possible to drain away. And that is the real challenge now in the countries having focused on these mid-level providers. The 13 years, I hope you understood me correctly, of these 13 years they have, as against my own academic 12, these 13 years are in service. They are working as nurses in the theater, they are working as intensive care providers, etc. So they are not away from practical work, they're in practical work while they are trained to become these people.
Thank you for the very important question. I think in 1995, the Commonwealth Health Ministers met and discussed this problem. And what they suggested was that developed countries should start producing their own doctors and not depend on doctors coming from other countries to work there. So in the United Kingdom, they made a change in 1995 where they had to put 10 additional new medical schools to train the doctors themselves and spend virtually about £250,000 on each of those people. So from about last 4 years, the number of doctors coming from abroad is virtually less than 100, especially for training. So the developed countries have to make an effort. They have to make an effort to try and see that they produce their own doctors, and there will be only people coming for 2 or 3 years for training and not completely shift. Prior to that change, every year they had about 5,000 doctors being registered from other countries. So I think it's an effort on both sides. One has to make it attractive for the doctors to stay in their own countries, and secondly, the countries where they are going to, they have to make an effort to train their own doctors.
There's one problem of brain drain, and Arulkumaran, I agree completely with you. You know how many doctors Africa produces per year? That's about 5,000. The whole continent of Africa, about 5,000. Do you know how much Europe produces? 175,000 doctors per year. Still, we are out there not only draining, but some African colleague of mine said, Staffan, you could stop talking about brain drain, it's vacuum cleaning. And whatever word we use, the proper problem is there. We have push factors out of the hardship of rural areas in the poorest countries. They are pushing people out from the poor housing, poor career possibility, poor schooling for children. All of us would go. And then we have the pull factors from our side. Come to us, have a career, 2 cars, beautiful prospects for the future for the children. These are extremely malignant and evil synergistic factors when we look into the movement. We cannot hinder people from going to one country to another. That is not, we should not blame people who go, but we should definitely blame the system for allowing that to happen.
Thank you very much for that very important intervention. The next is Ila Ojila.
Hi, good evening. First of all, my name is Jaili. Yeah, it's okay. I was supposed to ask a question for the Prime Minister, but anyway, I'm going to ask a different question for both speakers. So, one one of the problems, I'm from the Philippines anyway, one of the problems of our country, and I'm sure from other countries as well, is our population. And the condition of our maternal health there is really, really fluctuating. So, in your opinion, do you think that population, specifically overpopulation, has a grave connection to reproductive health, to maternal health, and to anything related to health? And how can we address this problem? Thank you.
Thank you. Thank you very much for that question. I think one of the major problems in large countries where they have a big population, as I mentioned, India has 18 million births a year. 18 million is, they can overtake Norway in 4 years. Well, they can reproduce Norway 4 times in 1 year, the population. The problem actually is about how do you do the family planning, which is acceptable culturally for them. And also they are given a reassurance that it is good for them to space the family, because if they have too many children too quickly, they become anemic and so on and so forth. So in many other countries, it's about the offering of family planning help, as well as to encourage them to use it, to reassure them and make it more acceptable. Because some countries, they go and push intrauterine contraceptive devices, which women don't want. Some countries, they push tablets, they don't want. So it's really a plethora of family planning advice should be given in order for them to accept it, and also it should be available even in the simple villages, so as to speak, and somebody should be there to educate them. So one of the pictures I mentioned is about community mobilization, where the women from the village get together and they talk. Somebody comes and talks to them every month about various things. So these are things which has to start slowly, slowly, and to expand. Otherwise, what you're saying is absolutely true. When the population expands, they take a lot of resources in terms of not only health, but also nutrition and other important things, important for global warming as well.
But I guess what we do not want is back to the coercive population policies that were prevalent some decades ago. Before we change the paradigm to reproductive health and to individual rights. Andrew? Ivan?
Yeah, good evening. I want to first and foremost thank you. I'm Andrew from Nigeria. I want to first and foremost thank ISFiT for a program like this. And my questions goes to FIGO. Since we've been hearing of international aids to developing countries like Africa, I want to really ask to find out what is the plan, or what is FIGO and United Nations doing in regards to female genital mutilation. Because we in Africa, where I come from, we have a lot of genital mutilation, which is becoming rituals. And this actually has been affecting child mortality. Because if a child after birth, a female child has to undergo genital mutilation, and after that the child have hemorrhage and bleed to death. Or if a lady is about to get married, she has to undergo genital mutilation. And this act is very brutal, is very painful, and is very, very demoralizing. So no any financial aid, no any non-governmental organization, nothing is being said about it in terms of the MDG, and then what is the place of FIGO in this particular act. Thank you very much.
Can we get the other questions now?